which is part of our Executive Leadership Series program. My name is Sue Janzak, and I'm the Director of Marketing at Health Integrated. And today, I'm joined by Don Shivers and Paulina Valdez, also of our marketing team, to host today's event on outcomes reporting. It's all about perspective. In today's webinar, we're going to get to the heart of accurate outcomes reporting. But how do you know if you're actually measuring the right things? And how do you report how far you've come if you don't know where you started? Including valid comparison groups and outcomes analysis is a powerful approach to putting numbers in perspective. But how you use them can differ between population-based and risk-based analysis. And today, we're delighted to welcome Kyahn Kamali, Vice President of Strategic Informatics at Health Integrated, to explain the importance of these comparison groups, as well as the ins and outs of using them for outcomes analysis. Kyahn has deep and diverse expertise in IT, data informatics, analysis, and the use of data for driving business outcomes optimization. He has applied this expertise in a number of fields, including healthcare, finance and lending, the internet, and retail environments. Kyahn received his master's degree in health policy and management from the Johns Hopkins University School of Public Health. He has hands-on experience leading efforts across many analytic areas, including financial modeling, predictive modeling, marketing effectiveness evaluation, call center evaluations, return on investment, and other impact analyses. At Health Integrated, Kyahn oversees the informatics and outcomes reporting functions for the company's health management programs. Before we get started, just a couple of housekeeping items. We are recording today's presentation and will upload both the audio and PowerPoint to our website by tomorrow. We will also send you an email letting you know when it's available online at healthintegrated.com. To facilitate our presentation, all of our attendees have joined us on mute. Of course, we welcome and look forward to your questions, and we will allow plenty of time to answer them. Please feel free to submit your questions through the chat box function throughout the webinar. We will collect them and answer them following Kyahn's presentation. Should time run out before we're able to answer all of your questions, we will respond to each of them through a follow-up email personally. Also, you can see that we put up a quick poll. We're putting up a quick poll, actually, to get a better idea of the role each of you plays in outcomes analysis for your organizations. Please respond to this poll as quickly as you can. Do so now if you could. And we'll share the results shortly and incorporate those findings and adjust the presentation according to those needs throughout. And with that, I'd like to turn over the presentation to Kyahn to get us started. Kyahn?
Thanks, Sue. And thanks, everyone, for joining us today. It's a big topic for sure. We're only going to hit on certain aspects of it. I do look forward to a quick snapshot through the poll to see what your interests are, and I'll certainly adjust my comments to fit. Basically, what we're covering today centers around the fact that while overall outcomes can be measured through HEDIS-like scores, financial measures, overall member utilization rates, and the like, discerning the impact of individual programs targeting subsets of individuals in your populations can be much more complex. So our goal here is to, as the title says, make sure we have the right perspective and make sure we're measuring the right thing. Let me see how I work this here. Bear with me a sec. There we go. That's our welcome. So our agenda today, we're going to quickly go through our learning objectives. We'll run through an overview of a couple of the major designs towards these outcomes assessments. We'll take some time to drill into the specific approach used by Health Integrated, and then we'll spend plenty of time, I hope, with questions and discussion around both our model and how that might apply in your own setting. Let me just check with our moderators. Do we want to close that poll? It is closed, so I missed the answers up there. All right, they'll get me the answers, the responses in a second. So our objectives today, at the end of this hour, hopefully I've made clear the reasons why you need a valid comparison group. We'll look at a specific example of population-based versus risk-based analyses and understand the roles and differences of each. And again, you'll get some insight and understanding of Health Integrated's specific approach. We're going to keep this at a fairly layperson level. And again, we can get a little more technical in the questions if that's where interest takes us. So why do we need comparison groups? Certainly no intervention in our world here is an island. There are countless outside influences that can impact our measured results. Generally, we do not have the ability to randomize people into measurement groups. And we really need to, in that world, we need to control the impact of external factors the best we can so that in the end, we're able to avoid overstating the financial value and return on investment of these programs. And I just got our poll results. If anyone didn't see those as they came in, 31% hands-on outcomes analysis, 23% working with folks who perform those analyses. So over half the group pretty close to these sorts of analyses. 19% very interested in seeing the results coming out of those teams, and about a quarter of the folks in some other role. Good to know. So roughly half hands-on and half not. That's good to know. So, so today we're going to talk about the measurement of population care or disease management care program. Much of what we talk about today is applicable to case management. There are some differences there, but the core is the same. We've certainly applied these approaches to commercial, Medicare, Medicaid, and dual eligible populations. We look forward to the opportunity in a few short months to begin working with some of our clients' exchange populations as well. And certainly the approaches are going to be applicable in that setting as well. In our case today, we're going to focus on a program that's at the heart of Health Integrated Services, which is our Synergy Care Management Program for individuals with both chronic illness and psychosocial or behavioral health issues. Just very briefly for anyone not aware of the Synergy program, like many disease and care management programs, starts on the left with rules for identifying the correct target population. And in the blue, we go into an engagement mode, outreach and engagement. That involves both the member and the provider. Once we get that person engaged with the coach, that's the yellow section there where we're working with them to address the gaps in care and the psychosocial issues. And then where we come in here at the end, in the green, we want to be able to measure that those programs were cost-effective and impactful. Again, just a very quick background slide here, outlining the typical cost per population type and the reasons, again, why we're focusing on the chronically ill with psychosocial issues with costs 2 to 3 times the norm. So there are a couple at the very highest level. I've boiled it down to 3 main approaches for measuring outcomes. Certainly, if you can randomize your members into a randomized trial, that's great. Typically, with telephonic outreach-based programs, we don't have the luxury of randomization. With reach rates of 30 to 40% of members identified for programs, each person contact Each person contacted by our teams and engaging with the coach is critical. Randomization may have a role in testing program A versus B, but really for us not in a participant versus a non-participant type of measurement. So mostly what we're going to focus today is on population-based models, which tend to be pre-post or following a population over time, versus a member-level participant versus non-participant model. So first, let's talk about the population-based model. Certainly, the Care Continuum Alliance, probably the most widely recognized source of documentation of what this approach is all about. Basically, you're talking about an overall look at all chronic members. Some will receive a high-touch intervention, some will receive a low-touch intervention, and some may have no direct interaction with the intervention at all. But you're taking a holistic look at the entire, in this slide case, diabetic, or often the entire chronically ill pool may include more than one condition. Here, the pre-intervention period is used as a comparison group for the post-intervention results. In this example from the slide, the 2 base years in the Care Continuum Alliance model, the 2 base years are averaged to give a starting per member per month rate. The using a medical cost inflation factor, the costs from that point are projected forward in time, and actual costs are measured. And the gap between those blue and the red lines are essentially the bending of the curve and the savings created by that in that population against the expected path. The good side of the Care Continuum Alliance model, it is very transparent, easily reproducible with fairly limited technical requirements behind it. Putting out a standard approach and making it very clear certainly allows for open discussion about the strengths and weaknesses, just like we're doing now. The pre-post rules are consistent, do not directly promote regression to the mean. Basically, you're doing what you can to ensure that you've independently applied the same set of selection rules to each year in the analysis to find your measure group. There's no once in, always in here, although certainly with chronic conditions, you're expecting a common core to continue throughout the measurement cycle. Some of the challenges with the Care Continuum approach, it is heavily trend factor dependent, especially as you get into the 3rd, 4th, 5th year. Your results can vary widely based on the selection of what is considered an appropriate trend. In health plan populations, you may have high levels of churn. In employer groups, potentially in some employer groups you may have lower levels of churn, and some you may have higher. I've worked with retail automotive parts client in the past that had a 30% turnover in their retail clerk base, which represented the majority of their employees. And certainly in any aspect, any population where you have those high levels of churn, you need to consider whether the folks coming in are coming in with different medical profile, looking at a risk adjustment year over year. With this population view, you're not controlling for most of those outside factors, and that certainly is a very large concern here. This basically, to sum up, this basically was a good approach for disease management 1.0, where there wasn't much in place before, and we're looking for a first approach. it's perhaps not the best model for where we want to be in the future. Switching gears to the risk-based model, in health integrated approach, we're targeting very specific high-risk individuals. We're assuming that the low-risk individuals are managed by their primary care provider, other general educational programs provided by the health plan, their employer, or the government, or some other source. We're going specifically after a high-risk and or high-cost subset of the population. Here, our comparison group is going to be those who participate and their experience over time compared to those who do not. And there's an example of essentially what that view of the population that's participating on the left versus on the right. That's the kind of comparison that we're looking at. The benefits of the good side of the health integrated model: measurements specifically targeting members with intervention, as opposed to the population approach. If you don't ever reach the member, they're not included in your measurement. The timing is individualized to each member's own intervention period, which helps minimize the outside influences. Our focus is generally a 12-month pre-intervention versus post-intervention. So you generally have somewhere between 12 and 24 months of experience with each individual member, and there's less time for external influences to change practice, costs, policies, etc. in the outside. The treated and the untreated groups are selected on roughly the same time frames. Every time we're selecting a high-risk member for an intervention, we're also picking up members at that same point in time that will end up in our comparison pool. So we're limiting our analysis to something on the order of a 12-month average in the pre versus the post period, and your medical cost inflation, for that is generally fairly well known and much less uncertainty in how to compare the pre and the post there. There are some challenges with this approach, though. Members coming into the program are typically at a point of abnormally high claims activity. Unlike the housing bubble 10 years ago, we know that those members' costs are coming down. Basically, if we look at the graph down at the bottom as just a illustrative of monthly claims activity, generally we look at a 12-month retrospective view to identify members for the intervention, and if in that first month, or in that first 12-month view, the member is not flagging for the program. Whoops, I went the wrong way. One more time. In the second 12-month view a month later, if there was a high cost or high acuity triggering event occurring, that event generally is happening in the last 30 days of claims history. Otherwise, they would have triggered in the prior month. So generally, we're picking folks up, which is great from an operational perspective. We're picking people up at a moment of need and awareness, but we are picking them up at a very high point in their medical cost, typically. And so we are aware that even if you do nothing, those costs are going to come back down. So gross savings will always be high, and adjustment there is critical to understand whether the program brought those down further or faster. Members in our group also typically have 4 to 6 comorbid conditions, especially with our vulnerable Medicare, Medicaid folks. 40 to 60% of those have behavioral health issues as well. Generally, what the message there is, we're left with a population that has greater variability across costs. And again, the comparison group is critical to control for that. When you look at gross savings, typically we'll see, again, because of the high cost nature of these folks and the point in time that we're recruiting them into programs, your gross savings can be 5, 6, or even 10 to 1 in terms of program ROI. And that's definitely not truth there, and it requires the comparison group to take out those effects of regression to the mean. Just to quickly recap what we've covered here so far, certainly there's a role for overall HEDIS cost and utilization measures across the entire population. They provide the backdrop of how your entire population is doing. They don't, unfortunately, of course, help you pinpoint which interventions are most effective and or cost effective. Using the population perspective, it's difficult, again, to assess the individual components of your whole suite of interventions. Targeting the high-risk members is always going to show a strong short-term financial and also strong short-term utilization gains. You need to get the comparison group in place to benchmark against to adjust back to the true impact of the programs. So let's jump right into the health integrated method of developing these comparison groups. We're not trying to predict future population costs here, but rather to ensure that we're benchmarking groups of participants against like members. You can use global future cost scores from sources such as the Medicare HCCs, United's Impact Pro, ACG scoring, etc. Those will result in blended populations that may be harder to tie back to program design and may not provide sufficient feedback to support future program enhancements. Health Integrated prefers to deconstruct those global scores into individual core driving elements as listed here. So we break our, we'll go into the details here, but age, gender, disease burden, cost ranges, and our own measure of recency of utilization of services. Depending on how many we cut those groups, we end up with about 72 matching categories typically. So where do we draw our comparison group members from? So we have our engaged population. We've gone through that stratification process. We've gone through, let's back up, the identification process across our whole population. We found those folks with the chronic illness, the behavioral health issues. We stratified those folks to give ourselves some prioritization of them. We've engaged some portion of those members. Typically, we'll engage 20 to 30% of the identification pool. We'll have a similar size group of members that we will reach on the phone, and they will decline participation. And then the remainder are those who, for a number of reasons, we've failed to reach. Those reasons include they have lost eligibility during the program, they have invalid or missing contact information, they don't like to answer the phone when they see members they don't know, and they don't like to respond to mailings, etc. But basically, we have the engaged pool, the declining pool, and what we would call an unable to reach pool. The declining folks, we definitely believe, have some clear selection bias. They were identified through the same means. They talked to one of our outreach specialists, and they decided the program was not important to them at that moment. So we're not going to use them as our comparison set. Instead, we're going to use the unable to reach group, roughly twice the size of the engaged pool. There may be some biases there, You could certainly think of any number of potential biases to test. But we're going to take randomly, we're going to match randomly roughly half of that group to our engaged population, and hope that, again, by not using the entire pool, we're using a third to a half of the pool, that we're going to avoid any focus on extreme members in that unable to reach group. So going through area by area, gender certainly straightforward. These are four of our 5 main matching areas. So gender first. Age, generally we break our populations into 2 or 3 age ranges, depending on the type of the population. All of these divisions are best assigned following some review of the population's characteristics. Disease burden, we have a measure that we use that accommodates both the number of comorbidities and the intensity of the overall burden of diseases. And finally, we break the members into cost categories. Generally, we use a low, high, and extreme binning, so we take anywhere from the top 10 to 20% of the folks as one group, and treat the high-cost extremes. We try to match high-cost extremes to make sure we're not, again, matching a group that was naturally going to come down strongly in cost versus groups that would not expect that sort of extreme. Those are our 4 fairly straightforward matching constructs. The 5th is what we call our momentum index, and this came about a year ago as an enhancement to the core matching that was in place at the time. When we looked at our team looked at the various outcomes, the cost savings outcomes across those comorbidity, cost, age, etc. There basically was a U-shaped relationship where the highest and the worst savings were both associated with increasing risk. What we discovered here, or what we came to the realization of, was that, and it's very simplified here in the graphic at the bottom, there are basically folks with our targeted sets of chronic illness and psychosocial issues who are coming immediately off of an inpatient event or some other high acuity, high utilization period of time, and they exhibit differences, of course, in their cost and utilization behavior than folks who are coming through a much quieter period in their experience. So we developed a scoring method to quantify what is basically a recency and intensity of utilization, and that, coupled with the age, gender, cost, and comorbidity, took out these abnormal effects and gave us much more predictable linear relationships in our results. Final thing, so after we put those 5 components in place, if you recall, we were concerned about the selection bias potential with those who declined the program for sure. With the folks who were unable to reach, we also were concerned that as we reach folks on the phone, half of them were declining the program, half were accepting the program. We're concerned that the unable to reach still, because this is a general identification script looking at claims, medical pharmacy claims and other sources, that we may be picking up too many false positives in that script and allowing them to flow into our comparison group. So we did some analysis of the claims histories of our identified pool and determined that there are some sub-segments that that we believe were not indicative of the target member. Basically, example would be an individual whose qualifying claims activity and spend all occurred within a single month out of the 12 months of the history. We're trying to avoid that sort of extreme. So this is not a matching criteria between participants and none, but is more a criteria to try to avoid what we believe is bias, or you could call it a gap that we see in the identification code over-identifying. So there's certainly the opportunity to step back and look at whether in your design of the comparison group you have correctly, to the best of your ability, controlled any known or perceived selection biases. So just a quick summary of the health integrated approach. What we know for sure, the highest priority is to have a comparison group. You cannot measure these high-risk programs in a vacuum. Where you draw your comparison population from, as we were just talking about, requires some thought to avoid the introduction of selection biases. Our model uses age, gender, condition acuity, historical cost levels over the past year, and a measure of recency of acute events to create those matched comparisons. And that's the summary of our approach. And what I'd like to do is show you briefly how that comes together. So typically, a little more background here just on again, some of the ground rules that are in place when we do have a lot of hands-on folks here. This is probably not new to any of you, but just to recap, typically both population and risk-based approaches look at the entire member's cost during the measurement period. They're not just looking at costs within a condition category. Many programs will exclude pharmacy costs from the ROI outcomes analysis, health integrated included. There's certainly strong arguments to be made for including or excluding those pharmacy costs depending on what your intention is. It's definitely an area that requires some consideration on the purpose for including or excluding pharmacy costs. Typically, members must be eligible for at least 6 months in each of the measurement periods. Often certain conditions, when you get down to the point of producing a return on investment calculation, certain conditions such as cancer likely exclude members from the analysis set. And finally, most folks introduce some form of stop-loss capping of individual member claims spend. So here we see some illustrative pieces of recent results from Health Integrated Synergy Program. As I mentioned previously, we can also apply the same approach to measuring complex case management, and generally this is applicable across commercial Medicare, Medicaid programs. Certainly in the case of exchanges, with your lack of historical claims activity, any of these approaches are going to take some time before the population size and the activity baseline has been laid down. In the top grid, we're taking a look at the matching groups in the column labeled matching label, where the first digit, for example, here represents male. The second one indicates the younger age bin, etc., across the 5 domains that we matched on. Here you can see the claims and member months pre and post by comparison group bucket. Note that not all the comparison, not all the participant groups, the matching groups on the right side have corresponding matches on the left. We generally have folks to fill the buckets, but not all the time, of course. In this case, we were oversampling the comparison side and trying to get to a 2-to-1 matching ratio. This was, the top part here is really an exploratory effort, not a client deliverable. In the lower grid, we're taking those, the top is an interim look, if you will, to the claims data rolled up by member and member group. In the lower grid, we roll that up further into the participant and the comparison groups. And here we're looking at a different client experience where we summarize those. And we get our first look at the gross ROI of 5.3 and the effects of adjusting for our comparison group, which brings the net ROI down to a more reasonable 2.7. From this view, we can also start testing the plausibility of our outcomes model. First, looking at the overall population size, again, we've lost about 120 people where there weren't folks in the comparison set available to populate the matching cells. We can look at the effects of the per member per month. So the samples we pulled, roughly the same initial cost profile in their 12-month history. We can look at the measured impact pre-post on savings and compare that to the changes we see in inpatient utilization activity to ensure that, for example, the strong driver of inpatient admissions is in line with the observed financial outcomes. We're always happy to have additional plausibility tests of our outcomes. We learn a lot each time we take another view of these results, and I just want to run through a couple more examples of plausibility testing. So on the, certainly around that idea, the first building block of program outcomes is having a program intervention that works, of course. Once you have an effective intervention, you can affect cost efficiency, scale, and other factors as you build towards creating a positive program return on investment. That first level of ROI plausibility comes from participation volumes. Did you actually engage members and sufficient members to support the fixed and variable costs associated with the program? The second level of plausibility comes from clinical and behavioral change monitoring among the participants. Did you actually change anything in the folks that you worked with? And the third comes from the results of that, where you're looking at service utilization, especially among inpatient admissions, readmissions, ER use, etc. Do the trends in those measures across participant and non-participant groups follow the direction of the financial savings? So that's what we were just looking at on the previous slide and what's represented here on the left. From the gross perspective, for example, you see extreme reductions in utilization, but you also see the fact that the non-managed population was also showing 20% reductions in utilization as well with no intervention. On the right side, we see an example of following a cohort over longer periods of time to further ensure impact on costs and utilization was not just a short-term effort. And again, these are just different ways of testing your results to make sure that they are working the way one would expect. Another example of plausibility testing. This is in a single, so here we're seeking to verify that intervened members who show cost savings are doing so basically by addressing those known gaps in care. That was that second level of plausibility I was talking about. Did we change clinical measures? If so, we can expect that that would have yielded financial value. Here's an example from a client, Care Oregon, who has a medical home program covering a fairly large portion of their population, and this allowed a good side-by-side testing of cost, satisfaction, and HEDIS scores. Here the client had a third party through the university there in Portland conducting an external test of HEDIS performance in their various subgroups. The all-in blue group is a blend of the client's medical home and Health Integrated's non-participant groups. While we can't claim causality from this view, if we follow the same approach outlined previously and assuming that the non-participant population is roughly 2 times the size of our engaged and exhibiting similar characteristics medically, we're still very encouraged by the separation of results, which again lends plausibility to our claims that the synergy intervention is leading to positive returns for our client. And another aspect of the plausibility of this one here, again, is that they broke the program into the higher touch intervention group versus the lower touch educational materials based assessment subgroup. And it's also encouraging from a plausibility standpoint to see that the higher touch program is having the stronger effect. So to summarize, in settings where the preference is to focus on high-cost, high-risk member intervention, extreme care must be taken to avoid overstating the results, as these members will typically experience large natural regression to the mean effects. As you're developing your own models, I think some of the core building blocks, really transparency. You want the discussion to be about the building blocks of your intervention and your measurement, and not about your choice of metrics or your statistical modeling prowess. While there's an important role for more rigorous analyses, perhaps those are on larger populations or on less frequent intervals. The greater time and resources associated with those almost demand that they're less frequently used, and they may not provide the frequency and detail of feedback that you're hoping for back to the program. You certainly want the results to be reproducible over time. For us, we need our results to be reproducible by our clients, and we want our results to be reproducible internally. We want to be able to provide our clients with a reasonable expectation of expected performance, and to have confidence that with the same intervention we're going to see the same effects. Finally, again, alignment with program parameters. For us, it's very important that the model not be so obtuse, that we want the key performance information to get back in the hands of operations and our product development staff. We like our model's ability to provide this feedback into our program identification and stratification logic, our member messaging logic, and the messages, individual messages that go out to subsets of the population, et cetera. So that is what I had for you in the presentation. Thanks for attending and bearing with me here. We appreciate your interest and welcome thoughts and questions. If you have any at the moment, go ahead. I know we've got a couple here already. So let me see. Does Sue want to say something here?
Actually, Kyahn, that was a great presentation. I really appreciate it. And we have quite a few questions for you. So I'm not going to say any more. I want to make sure that we can answer as many of these as we possibly can. So Don, Kyahn, if you want to just go ahead and start reading those questions and digging in, that would be great.
Absolutely. Kyahn, the first question that we have today states that this person has a health plan-based DM program targeting 2 conditions. Their question is, how does what you've outlined here today apply to their situation?
Hey, Don, thank you. Certainly that that comes up often with our clients, and the general answer to how you measure a disease management program that's essentially embedded in a much broader situation there. Both the population-based and the participant-focused approaches that we outlined here today can have their roles there. The population view of per member per month cost, utilization, gaps in care measures, HEDIS scores, et cetera, performed repeatedly over time, especially when they're coupled with some form of risk adjustment or cohort tracking, can provide valid measures of the cost per member within the populations. And you'd certainly like to see those measures flat or showing gains. Depending on the size of your engaged groups, perhaps you can sub-segment those measures into levels of engagement, as we were looking at with the Care Oregon example, and quantify the effects of measure group differences there. You're still going to have a lot of outside influences in that sort of population view. Alternatively, you can use the population measures to monitor total costs and use a participant-focused approach, such as the health integrated approach, to quantify the program impact specifically. If you have a 20% per member per month savings in an engaged subset that makes up 10% of your total chronic population, of course it's a very high cost total chronic subset of that 10%. At the population view, then you're looking at 20% of 10%, or you're looking for a 2% effect across the entire population. That may easily be swamped by uncertainty and variability in the population view, but in the participant level analysis, your impact will be much clearer. So I see we have another. Okay.
We do. We have
Don?
another question. Yes, it's do you use a specific tool in your initial screening, or is it homegrown?
We use, thanks, Don. We use our homegrown tool. We have in the past used outside tools. Most recently, we were a licensee to the Impact Pro tool. We're certainly aware of the capabilities of outside tools. We like the flexibility of our tool. We've been in this particular niche, if you will, of the business of looking specifically at chronically ill individuals with behavioral health issues for, somebody will correct me, close to 15 years. We have a lot of experience on our team here. So we have a pretty good sense of what we're looking for, and we found that having control of our own tool allows us to get what we want out of, again, the different Medicare, Medicaid, commercial populations. So we use our own tool. Another question, Don?
Thanks, Kyahn. Yes, we do. Why doesn't it make sense to use members who did not take the intervention in the population you couldn't reach as part of the control group or the comparison group?
Okay, excellent question. And I think that when you, as an analyst, you have to take a pretty holistic view of this. It's not just about the measurement. Remember that this all starts with those same screening tools that we were just talking about, whether that's Impact Pro or the homegrown tool. We're still scanning medical and pharmacy claims, maybe health assessments, maybe other sources, and we're still making our best assessment of member needs through data sources. We're not talking to the patient or the member yet. We're not talking to the primary care provider. We're using stratification logic to identify folks we think are interested in the program. I think the fact that when we get the member on the phone, that half are declining, certainly you have to get into those reasons, but many of those folks are declining because they do not see a need. They've got some other, either they're denying the condition, they've got some other plan, they have a good social support network, they have a great relationship with their physician, they're in a hospital-based program. They do not see a need for our program. The folks who engage do see a need. They had none of those other support systems in place. We believe that is a vast difference. Now, some of the folks we do not reach on the phone will, if we did reach them, they would also separate into those two camps, certainly. But it's much clearer in the declining group that they were expressing their different situation. So we know that the declining group is definitely is different, and certainly. So again, it's not perfect. The unable to reach group has, you could say the decline group has known bias, and the unable to reach group has unknown but potentially less bias. And we can certainly still do ad hoc analyses across those three populations, both in terms of outcomes and also by going back and exploring further with the operations folks the various reasons why people were declining. And certainly, you know, those are valuable efforts to undertake both at Health Integrated and, you know, in your own program.
Thanks, Kyahn. We have another question. Can you talk a little bit about the impact of churn? How do you see it impacting risk-based analysis, if at all?
The let's see. Well, with the member level, I think, you know, again it's whether you, the question is again whether you want to think just about the measurement and the impact on measurement, or if you want to think about the impact on the entire population. At the measurement level, it's fairly straightforward. The member has to have at least a minimum number of months with the plan in the program, basically, before and after the intervention, whether that's 6 months, 12 months, wherever you set that. You know, so churn at that level disqualifies you from the measurement and potentially only works against you in terms of cost. You incurred some cost to manage that person, and you don't get to, pardon me for that message, you don't get to take the credit for any change that might have happened. At the same time, the reason we're going after high-cost, high-risk individuals in a population is to try to impact the overall profile, cost and health profile of that entire population. And so certainly, as the graphic showed, you know, where we believe in the work we've done in the past that the results from our program extend into second and third year gains. Certainly with churn, you're basically, again, throwing that person out and picking up another person who may put you right back at the same initial risk level. So churn at the measurement level slightly reduces our potential return on investment because we're picking up costs of measuring person, but we're unable to quantify their gains. Churn at the global level is really hurting our impact at the population level to do what we're trying to do, which is address those 10% of the people that are responsible for 80%, 70% of the cost.
Okay, great. Kyahn, thank you so much for answering all the questions and again for your presentation today. We're at about time, so I'm going to cut off the questions. If there's any additional ones there, we will certainly respond to them privately. So thank you all for joining us today. And please join us again next month when Fred Davis, the Director of the SNP Model of Care Program Delivery for Health Integrated, will present Delivering Compliant Models of Care that Meet the Mandates. And that will take place on Wednesday, August 21st at 2 p.m. Eastern Time. Please watch your emails and our website for registration information. And this concludes today's webinar.